There's a staffing crisis in New York State which compromises patient care. As nurses, we see how understaffing puts our patients and staff at increased risk of preventable injury and even death. The number of patients assigned to a nurse has a direct impact on the quality of care one nurse can provide. To fill the void, nurse-to-patient assignments are often placed at 1 to 5, 1 to 7, and have been up to 1 to 9. The ratios often supersede the evidence-based practice recommendations in relation to our floor, 3 West, 1 to 4 for medical surgical patients, 1 to 3 for step-down telemetry, and 1 to 3 for pediatrics. I am in complete support of the solution that has been presented through Bill number A01532, which enacts the Safe Staffing for Quality Care Act, mandating set nurse-to-patient staffing ratios in New York healthcare facilities. In 2004, California became the first state to mandate hospital staffing ratios by law. In comparison to California's success over the past 14 years, evidence-based research has proven that minimum staffing ratios recommendation ensure quality of care that is expected. See Appendix B. Imperative to quality patient care and compromised by understaffing, staffing by acuity is especially important to patients and providers as it promotes best practices, incorporating ample time to carry out patient-specific nursing tasks following evidence-based practice recommendations, thereby reducing preventable patient-staff harm, time for patient-nurse interaction, allowing nurse to better advocate for patients and their families, supporting proper discharge preparation, which all in turn increases patient satisfaction. Acuity is described by the measurement of intensity of care by a patient. An acuity-based staffing system regulates the number of nurses on a shift according to the patient's needs, with a maximum acuity score of 100, rather than patient quantity. Patient care levels must also account for an estimation of patient volume that includes admissions, discharges, observation patients, real-time patient census, and a leeway for fluctuating staffing needs to accommodate for changes in patient volume, acuity, and the resulting workload. Despite California's success, New York State hospital administrators are desperate to maintain power over staffing. The bill is important to healthcare providers because enforcing minimum staffing ratios will guarantee facility compliance and improve the work environment, in turn helping to reduce employee burnout, increase staff retention, and assist with healthcare providers performing quality care. The fight for change in Congress. Announced by the New York State Nurses Association, many hospital managers are campaigning against New York State's nurses' efforts to enforce staffing laws by spreading the following myths on how mandated staffing ratios will do more harm than good. In refute, nurses have prepared factual evidence proving that these myths are just that, myths. Myth 1. There's no direct link between mandated nurse staffing ratios and improved patient outcomes. Fact. The number of patients assigned to a nurse has direct impact on our ability to appropriately assess, monitor, and care for, safely discharge our patients. Hospitals which routinely staff with 1 to 8 nurse-patient ratios experience 5 additional deaths per 1,000 patients than those staffing with 1 to 4. The odds of patient death increases by 7% for each additional patient the nurse must take on at one time. Research demonstrates that lives are saved, quality of care is improved, and hospital stays are shorter in states which hospitals meet the California state benchmarks. Myth 2. Mandated staffing ratios could force hospitals to close or cut services, which could compromise access to care. fact, not one California hospital closed because of ratio implementation. In California, hospital income rose dramatically after ratios were implemented, from $12.5 billion from 94 to 2003 to more than $20.6 billion from 2004 to 2010. There was no evidence linking changes in hospital finances to the implementation of staffing ratios. In fact, some managers reported that staffing legislation made it easier to secure funding. Myth 3. Safe staffing ratios would cost New York hospitals and nursing homes too much. Fact. Safe staffing is a cost-effective way to improve patient care and lead to savings for hospitals and healthcare systems. Inadequate staffing directly correlates with nursing turnover and poor patient satisfaction. These costs and the negative consequences of poor staffing increases the cost of care. Turnover is expensive. The average cost to replace an RN ranges from approximately $82,000 to $88,000. Nurse understaffing increases the risk of pneumonia and other preventable infections that can add thousands of dollars to cost of care and may lead to avoidable deaths. Hospital-acquired pressure ulcers alone are estimated to cost of $8.5 billion per year. Myth 4. Hospitals need flexibility in staffing. Fixed ratios won't meet the needs of patients. Fact. The ratio set at a minimum standard base of research evidence, practices, and the experience in California. The bill requires facilities to use unit-specific systems to determine patient care needs while considering admissions, discharges, equipment, and administrative needs. No averaging. The ratios are the number of patients assigned to an RN at all times during the shift. Facilities have flexibility to assign nurses fewer patients according to acuity, but no nurse can be assigned responsibility for more patients than the set ratio. Hospitals that violate this law will face civil penalties. Floats. The law requires hospitals to staff units using nurses who have been oriented to and have demonstrated competence in the clinical area. Use of agency nurses should be avoided. Myth 5. Hospitals have to lay off other caregivers if safe staffing ratios are implemented. Fact. Non-nurse staffing levels at hospitals increased by 64% since 2005 after safe staffing ratios were implemented in California. Hospitals cannot count assistive personnel towards licensed nurse-to-patient ratios. Ancillary staff continues to be vital to the healthcare team. In fact, the bill requires hospitals to maintain an appropriate level of caregiver staff, equipment, and administrative staff. See Appendix C. As healthcare providers, we all have been affected on a personal level in regards to staffing. And yes, Glens Falls Hospital currently utilizes a staffing by acuity-based program for patient assignments. However, without a law to govern staffing, there are flaws within our system. Non-compliance with the assignment manager may be due to lack of know-how or non-use altogether. The floor may be adequately staffed due to underestimation of an influx of patients, an unexpected call-in, forcing nurses to absorb other employees' assignments. Most often, patient-technician staffing is not adequate for the intensity of care required by specific patients admitted to 3 West. And a common occurrence is when an A&M is not scheduled, the staff floor nurse is forced to take on a role of charge nurse, often in addition to patient assignments of 4 or 5. Safe nurse staffing reduces avoidable adverse patient outcomes, so it's imperative that these voids in staffing are addressed. For both the constituent, the average person, or who is or someday may be a patient, and for the healthcare providers who are working hard to provide quality care. As a constituent and a healthcare provider, it is extremely important to look at the bigger picture here. Hospital-acquired preventable injury is one unfortunate outcome of understaffing. Research has demonstrated that hospitals with lower nurse staffing levels have higher rates of pneumonia, shock, cardiac arrest, urinary tract infections, and upper gastrointestinal bleeds, all leading to higher cost and mortality. The Centers for Disease Control and Prevention report an estimated cost of $1.7 million in healthcare-associated infections throughout U.S. hospitals each year, with 99,000 consequential deaths and an average preventable added expense of $20 billion. A broad range of research demonstrates that increased staffing levels do not diminish the profitability of facilities. See Appendix D. In summary, analysis of statistical evidence gathered over the past 14 years supports nurses lobbying for law, revealing direct correlation between California minimum staffing ratio, mandates, and fewer negative outcomes for patients and staff. Nursing workforce costs may rise, but that increase is mitigated by overall savings from improved patient outcomes and avoided adverse events, leading to long-term savings for hospitals while lowering overall healthcare system costs. So I have to ask, are you with me in the fight to improve staffing ratios and improve patient care? Can you give me a vote yes?
Yes.
Yes.
All right then.